Good morning, everyone. Respected Professor V.K. Kapoor sir, Professor Yogesh Vashisht sir, senior faculty members, and my colleagues. Today, I'll be talking about the surgical management of the carcinoma stomach. So, today's discussion will entirely cover on the surgical aspects of the management of carcinoma stomach. A cursory look at the TNM clinical TNM staging of carcinoma stomach reveals three things. Broadly, the carcinoma stomach can be divided into three groups. The carcinoma coming under the early cancer group, with the second being the locally advanced group, and third being the metastatic groups. One of the most significant factor which influences outcome in these three set of patients is the risk of lymph nodal metastasis. It can be as low as 80. It can be as low as 10 to 20% in the early stage of the carcinoma stomach, increasing up to 75 to 80% as the stage advances. As we know, the prognostic factors in any malignancy depends mainly on the performance status of the patient. The better the functional status of the patient, the outcome is likely to be better. The early stage of tumor will definitely have a better outcome. Absence of lymphadenopathy is also a good factor. And when we plan a surgical management, ability to get a R0 resection will definitely influence a good outcome. And as we know, the biology is a king. Intestinal type of carcinomas definitely have a better prognosis. So based on these broad principles, gastric cancer management can be divided from the surgical viewpoint into two broader headings. Management in those patients who have got a resectable disease and management in a metastatic setting. In the resectable disease, it can be again further divided into early gastric cancer and those patients with locally advanced gastric cancer. In early gastric cancer, endoscopic therapy is primarily advocated as a mode of therapy, which is used as a step-up approach. If the endoscopic therapy fails, then we can bring in other modalities of management, other surgical modalities of management. In locally advanced gastric cancer, now the treatment has moved into era of multimodality therapy, with surgery being advocated as a primary modality therapy, and the surgery is usually sandwiched or surgery is followed by chemotherapy in the adjuvant setting. In the metastatic disease, we will discuss about multivisceral resections and management in those patients who come with gastric outlet obstruction, bleeding, or in the complication of perforation. So today I'm planning to cover all these topics. So to start with early gastric cancer. So early gastric cancer diagnosis usually happens in a setting of in a setting where endoscopic screening is regularly followed. So usually the diagnosis is picked up on a white light endoscopy. So white light endoscopy, the features to suggest there is a suspicion of gastric cancer is the surface irregularity. Surface irregularity, there can be a small growth lesion, and you have to look for a presence of a demarcation line. These findings will be further accentuated by use of chroma endoscopy using indigo carmine dye. In the Japanese literature, the early gastric cancer, they have divided into multiple subtypes: the protruded type, superficial elevated, flat type, superficial depressed type, and excavated type. The significance of this is the protruded types are usually likely to be well differentiated tumors, and as the tumor excavates and ulcerates, it's most likely to end up in a poorly differentiated subtype. So what exactly is a early gastric cancer when it comes to histopathological subtypes? Early gastric cancers are those cancers which are limited to mucosa and to some extent the early part of the submucosa. So what is histologically called as SM1 subtypes. So what are the therapeutic options we have in this early gastric cancer? Mainly it is based on endoscopic management. There's endoscopic mucosal resection, EMR, ESD, to some extent limited surgical resection, and if all these fails, gastrectomy as a therapeutic modality. What is the philosophy of offering endoscopic resections in patients with early gastric cancer? So the main concept is based on organ preservation. If you're able to preserve the organ, the patient is going to have a better quality of life, and with the better quality of life, the outcome is expected to be better. So, and doing an endoscopic modality of treatment will no way affect your ability to look for the evidence of a metachronous lesions, and will not impede further surgical management also. So the first modality is usually advocated for endoscopic management is endoscopic mucosal resection, where the unhealthy or the diseased mucosa is removed along with a part of a surrounding healthy mucosa. This is usually done by using a high frequency steel snare wire. So basically the principle is we are going to inject lipid substance into the submucosa. As a result, the mucosa gets elevated. So then it's cut using a high frequency steel wire. It can be also be facilitated by using an endocaps or ligating devices. What's the main problem with the endoscopic mucosal resection? So when we deploy endoscopic mucosal resection as a therapeutic modality, we should be able to stage the disease well at the end of the procedure. The histopathological staging of a local state of the disease has to be good. If we are not able to, once we are able to do a staging of the disease well, so that will explain us about the risk of the lymph nodal involvement, because if the disease extends into the submucosa, the risk of the lymph nodal metastasis increases, and it will also explain us about the potential cure of the disease. So there are certain limitations with endoscopic mucosal resection. That is, usually you cannot deploy it to remove the lesion which is more than 2 centimeters. And whenever you try to do a resection with endoscopic mucosal resection, usually you end up doing a piecemeal resection. When you do a piecemeal resection, your histopathological analysis will be incomplete. So to overcome this modality, the Japanese came up with the concept of endoscopic submucosal dissection. So wherein the dissection happens in the submucosal plane. The problem is when we try to do dissection in the submucosal plane, we end up perforating the stomach. So to overcome that, they came up with the concept of insulated tip cautery. So with the insulated tip cautery and the variations of that. So with the insulated tip cautery, we can effectively dissect the submucosal plane. So basically, the principles of endoscopic submucosal dissection is we are going to mark the lesion which we are planning to resect. So then in the submucosal plane, the injection of either hypertonic or a normal saline happens, and the saline can be mixed with indigo carmine dye so as to limit the plane of dissection. So it will give us idea which plane we are dissecting. So then for a better traction, because we are going to do with a single scope endoscopic single channel endoscopy instrument, so we will not have a traction control over the tissue we are dissecting. So one of the way we can overcome that is by using a hemoclip. You attach a hemoclip to the area which you are going to dissect, and you can attach a dental floss to the other end of the hemoclip, and that is brought out of the oral cavity, and that can give us a traction from the other hand, and we can successfully dissect. So dissection happens in the submucosal plane, and once you have done successful dissection, most important step is you have to orient the specimen in a proper plane so that we can get a pathological information. So who are the patients, or what are the principles of offering endoscopic resection? So endoscopic resection can be offered under 3 headings or the 3 situations. One is as an absolute indication. So these are those set of patients where endoscopical mucosal resection acts as a standard treatment. That is, in these patients, the possibility of harboring a lymph nodal metastasis is less than 1%. That means in this set of patients, this endoscopical resection is expected to have a therapeutic effect. So that means these patients will not require any further surgical resection apart from a regular surveillance for this malignancy. In the expanded indications, this is not offered as a standard treatment but as an investigational treatment. These set of patients are also expected to have a lymph nodal metastasis less than 1%, but we don't have a sufficient evidence on a long-term outcome. And next is a relative indication, where these are the patients where endoscopic resection is not offered routinely as a therapeutic modality, but under some compelling clinical circumstances where the patient may not be fit for a surgery because of the comorbidities or advanced age. In these patients, it can be offered as a relative indication. Before going into the details of the patients whom we are to be offered, let's look into the Japanese guideline. In the Japanese system, when we offer an endoscopic resection, the final outcome of these patients is defined under something called as endoscopic curability. Endoscopic ability to obtain endoscopic curability. That is graded into 3 grades: endoscopic curability grade A, grade B, and grade C. So in those patients in whom the histopathological criteria, after certain histopathological criteria is satisfied, if they come into endoscopic curability grade A, these patients are not required to undergo any further surgical or any further therapeutic modality. They can be just kept under surveillance. In endoscopic curability B also, so they are also kept under follow-up, but they will require a little more extensive surveillance. So let's see what are those patients in whom we are going to offer endoscopic mucosal resection. So again, there are two headings. So endoscopic mucosal resection, or ESD, which is offered as an absolute indication. So these are those patients in whom the histopathology is expected to be differentiated type, well differentiated type, and there is no surface ulceration over the growth, and the histopathological depth is limited to T1A, and the tumor size is less than 2 centimeters. In these patients, you can do both either EMR or ESD. The problem is when the size of the tumor exceeds more than 2 centimeter, EMR fails, because you'll end up doing a piecemeal resection. So in those patients, ESD has a definitive role. So again, you can also do ESD in those patients where the surface of the lesion shows ulceration, but the size is less than 3 centimeters. Next is the situation where you can expand the role of the ESD, and that is called as expanded indications. Here we are stretching the limitations of dissection. We try to offer the tumor, we try to offer ESD to those tumors which have slightly invaded the submucosa, the early part of the submucosa involved. It's called as SM1. The size is limited up to 3 centimeters. So all these were well differentiated type. So it is also said that ESD can also be done in those patients where it is undifferentiated type with the size limited to 2 centimeters. So how do we follow up these patients after endoscopic intervention? Those patients who fulfill the criteria for a curative resection, that is, after all these histopathological criteria is fulfilled and the final histopathology also shows that the margins is cleared and there is no lymphovascular invasion, so they are said to be have achieved curative resection. Those patients are kept on a regular follow-up in the first year for every 6 months using endoscopy, and for the next 5 years they are expected to undergo yearly endoscopy or every once in 6 months, and for the subsequent 5 years also, so endoscopy has to be done every 6 months or once every 5 years. But when you do an endoscopic resection with an expanded indication, that is, in these patients, expanded indications, these patients involves a group of those patients where the tumor is invaded early part of the submucosa and undifferentiated tumors. These patients, in addition to regular endoscopic surveillance, so because we have expanded the criteria, so there is some amount of risk of lymph node metastasis. So they are expected to undergo cross-sectional imaging in the form of CT scan every 6 months to 12 months. But the final histopathological analysis, when the final histopathological analysis does not meet this criteria, where it comes as a possibility for non-curative resection, that means whether you ended up doing a piecemeal resection or only histological margin has come positive, in those patients, either you can offer a repeat endoscopic resection, or if the clinical indications are compiling you to not to under or a further surgical management, if it is not allowing you to undergo a further definitive open or laparoscopic surgery, then these patients can be kept on a regular surveillance. So to summarize, the role of endoscopic resection in early gastric cancer, it is feasible and it has to be done in those patients where the disease is limited to T1A with the size limitation extending up to 2 to 3 centimeters. So moving on to the next stage of management of patients in stage 2 and stage 3 disease, where the tumor has spread beyond the mucosal level to involve the submucosa, muscularis layer and the serosa, and there is a possibility of lymph nodal involvement. What are the general therapeutic goals in this set of patients? So we are trying to achieve a microscope. When we resect the tumor, the goal is to achieve a microscopically complete resection margin, that is R0 resection, and to dissect the lymphatic nodes, to dissect the lymphatic basins draining that area, and clear the peritoneal surfaces originating from the embryonic dorsal and ventral mesogastrium that includes the omentum and the bursa. So that, what is the goal of doing that? To reduce the risk of local recurrence and to facilitate adequate staging. And when we do this resection, we should be able to restore adequate gastrointestinal continuity. The basic principle to be understood in this patient is the surgical resection of the primary tumor and regional lymph node. Both constitutes a cornerstone of the treatment, but surgery is necessary but does not offer sufficient cure alone. Surgery has to be combined with the multimodality therapy. So once we decide that the patient has to undergo surgery, so let's understand the various terminologies which frequently come with gastric surgery. So these terminologies are derived from the Japanese gastric cancer treatment guidelines. So when we offer a surgery, it can be broadly offered under two headings: surgery when we offer with a curative intent, and surgery with a non-curative intent. So when we offer a surgery with a curative intent, it is there are two terminologies. One is called as standard gastrectomy and one is non-standard gastrectomy. So standard gastrectomy involves resection of at least 2/3 of the stomach with the T2 lymph node dissection, and when we vary with the amount of the stomach we remove, with plus or minus increasing or decreasing the amount of lymph nodes, then it is called as either modified or extended gastrectomy. And in non-curative surgery, we have got broadly two headings: surgery which is offered in the palliative setting, whereas to palliate the patient's symptoms in the form of obstruction, bleeding, etc., or reduction surgery. So reduction surgery is it's like a tumor debulking. So the surgery is offered to those patients who have got metastasis either in the liver and the peritoneum, but they do not have any symptoms related to the primary. So the aim of surgery is so to reduce the onset of symptoms. But the latest practice guidelines from the Japanese, they do not recommend doing the reduction surgery. We'll look into this at a later stage. So who are the patients in whom we should be offering gastrectomy? So as I said earlier, any patient who has got a clinically node positive status with the tumor extending from T1B to T4A onwards, they are offered surgery as a standard therapeutic modality. They are offered surgery as a standard therapeutic modality. So whenever possible, in a patient with a distal carcinoma stomach, distal gastrectomy is selected. So, but what about those patients who have got a tumors in an early stage? That is N0, for some reason your endoscopic mucosal resection fails, or those patients with T1 lesions. So what are the surgical options for them? In them, the concept is to go for a limited resection. So that is either we can go for a pylorus preserving gastrectomy or a proximal gastrectomy. So let's discuss about what type of surgery to be offered in a patient who has got a cancer involving a distal stomach. So distal stomach from the days of McNair in the 1950s. So he initially advocated the role of total gastrectomy over a distal gastrectomy, but over a certain amount of time, it was observed that the quality of life in those patients who undergo total gastrectomy is poor compared to those who undergo just a limited resection in the form of distal gastrectomy. So, and the total gastrectomy in these patients will not give will not affect the long-term quality of life, because the data from the French cooperative study trials also showed that the outcome in these patients is not determined by the extent of surgery you offer, but rather than by the stage of the disease. That is, whether the disease has extended up to the serosa and the extent of the lymph nodal involvement. So this review also shows that whenever you give a distal gastrectomy, when you offer a distal gastrectomy as a modality of patients with a distal stomach growth, so the that has a better outcome, because the total gastrectomy is associated with inferior long-term quality of life in the terms of in the form of early satiety, weight loss, and need for vitamin B12 supplementation, etc. And total gastrectomy is always associated with high risk of perioperative morbidity in the terms like in the form of increased postoperative complications rate, anastomotic leakage, wound complication, and peritoneal abscess. So whenever possible for a patient with a distal stomach growth, distal gastrectomy has a definitive role and is advantageous compared to that of a total gastrectomy. What about those patients with a growth in the proximal stomach? So the proximal stomach, there are two options. Either you can offer total gastrectomy or a proximal gastrectomy. But in our clinical practice, usually we do total gastrectomy because the proximal gastrectomy is associated with the significant risk of reflux esophagitis, which will impair the quality of life. So when we so once we decided that we are going to do either total gastrectomy or a distal gastrectomy, the next point to be determined is what about the resection margins. So for T1 tumors, the recommendation is the gross resection margin of at least 2 centimeters to be obtained. For those patients who have got the growth, the tumor depth of invasion is more than T1, so the Japanese guidelines recommend that you should get at least 3 centimeters margin in the setting of Gorman type 1 and type 2 growth. But those patients with type 3 and 4 growth, the margin length is increased to at least 5 centimeters. But the recommendations are also that in those patients who have got a diffuse type of carcinoma stomach, the recommended margin can extend up to 7 centimeters. Next, moving on to the concept of lymphadenectomy. So why do we do lymphadenectomy in gastric cancers? The reason for to do an adequate lymphadenectomy is to achieve adequate staging, because because the final outcome of the surgery is going to determine whether you have assessed the sufficient number of lymph nodes both surgically as well as pathologically, and it is proposed that some form of advanced extended lymphadenectomy may have a better therapeutic outcome. So what is the sufficient number of lymph nodes we have to harvest? So the current AJCC staging recommends that at least 16 lymph nodes to be harvested to assign a certain pathological stage to these patients. Before going into the further details of the lymphadenectomy classification, lymphadenectomy in detail, so let's briefly discuss about how do we classify the lymph node station. Sir, are you able to hear me? Hello.
Yes.
Yes. The classification of the nodal stations is extensively explained in the Japanese literature. So we are all familiar with the lymph nodal stations. I will not go into details of this. These are further images. So So let's go into the concept of how the concept of this lymphadenectomy evolved.
Reetesh, you should, take a minute and explain the three stations of
Okay, sir.
lymphadenectomy.
Yes,
I
yes,
think
sir.
that will be beneficial for the students.
Yes, sir.
You can use the other slide too. Yeah, it's more easy.
No, sir, I'll explain this. So the lymph node stations, the lymph node stations, one correspond to right paracardial lymph nodes, two is left paracardial, three is the nodes along the lesser curvature, four is lymph nodes along the greater curvature, five is suprapyloric, six is intrapyloric nodes, and seven constitutes the nodes along the left gastric. These 1 to 7 nodes are considered as tier 1 lymph nodes or the D1 station lymph nodes, which are considered as loco-regional nodes for the patient with the carcinoma stomach. Then lymph node stations from 8 to 12, they come under the second group of lymph nodes, which constitute D2 gastrectomy. These lymph nodes are located along the named vessels. That is the lymph nodes along the celiac axis, lymph nodes along the common hepatic artery, lymph nodes along the splenic artery, and lymph nodes from the splenic hilum. And further lymph nodes. So number 13 corresponds to lymph nodes which is situated along the posterior aspect of the head of the pancreas. Number 14 nodes along the root of the mesentery. 15 nodes along the transverse mesocolon, and 16 corresponds to lymph nodes along the paraaortic nodes. So again, the group 16 lymph nodes are further classified into 16A1, 16A2, B1, and B2. 16A1 corresponds to lymph nodes coming from the diaphragmatic hiatus of the aorta till the origin of the celiac axis. A2 is beyond that. That is from the celiac axis to superior border of the left renal vein. B1 is from the lower border of the left renal vein to the origin of the IMA, and B2 is the lymph nodes from the origin of the IMA to the bifurcation of the aorta. So now let's go into the concepts of evolution of lymphadenectomy. How did we get into from D1 to D2? So the extent of lymphadenectomy has been debated for a long because of the two issues. One is mainly for the feasibility to do and how safe it is. The traditional approach for lymphadenectomy in the Europe and in the Northern America has been D1, and Eastern Asia, in particular in Japan and Korea, they have been practicing D2 lymphadenectomy. So it all started the concept started evolving in the Western literature from the almost from the year 1950, when the McNair observed that those patients who underwent the traditional D1 lymphadenectomy, they had a very high rate of local recurrence. The local recurrence in the form of in the area of the tumor bed of the stomach, or in those from those lymphatic regions which have not been dissected as a part of an earlier surgery. So they came up with the concept that probably removing those additional lymph node stations will have some therapeutic benefits. So then they started investigating this with the hypothesis that maybe this removal of these additional lymph node stations will give some survival benefit. So in the Western literature, this was analyzed over a period of almost 40 to 50 years in the form of 6 RCTs. So these 6 RCTs, they followed something called as the Japanese rules for the lymph node classification. That is, they tried comparing D1 lymphadenectomy versus D2 lymphadenectomy. So D2 lymphadenectomy, as I said earlier, includes removal of all the lymph nodes in addition to D1, those structures which are originating from the ventral and dorsal mesogastrium, that including the distal tail of the pancreas and the spleen. So this is one study which is not much discussed in much of the literature. This came in the year 2004, report in the British Journal of Cancer. It was a prospective RCT where they compared D1 versus D2 gastrectomy. 118 patients were divided into two groups of D1 and D2 gastrectomy, 36 versus 82 patients. The outcome showed that those patients who had D2 distal gastrectomy, the survival in them was almost fourfold than that of those patients who underwent a D1 gastrectomy. And this was particularly evident for those patients who had got an advanced stage of cancer, that is stage 3 cancers. In their multivariate analysis, the T stage, N stage, and extent of lymphadenectomy were independently associated with duration of the survival. That means there is an evidence to show that D2 lymphadenectomy is beneficial.
Yeah, maybe you should point out this is the only study available in literature that directly shows in the first attempt that D2 is beneficial. All the other major trials, which I think you will show now, have only in subgroup analysis shown that D2 is beneficial. And
Yes,
this
sir.
was a study conducted in the UK, and they had randomized the patient based on postal codes where they were living. Yeah.
Yes, sir. So now let's go into the the trial, the six trials which I mentioned earlier, which compare D1 versus D2 lymphadenectomy. So these are the six trials which are done across the globe in the multiple centers. The trial by Dent et al. From South Africa, the study from Hong Kong, the Dutch trial, the MRC trial from UK, the study from Taiwan, and study from Italy. One of the biggest advantages of doing a D2 lymphadenectomy is we are able to harvest more number of lymph nodes. As it was shown by the Dutch trial, the number of lymph nodes was almost double, 17 in the patients who underwent D1 gastrectomy compared to those who underwent a D2 gastrectomy. So we are able to harvest more lymph nodes. Maybe that means your staging might be more accurate. But D2 lymphadenectomy traditionally has been associated with a lot of problems. So let's look into that. So what is the problem associated with D2 lymphadenectomy in terms of morbidity and mortality? So D2 lymphadenectomy, because you are going to do an extensive resection, is definitely is going to be associated with higher morbidity. This has been confirmed across all the trials. So in the UK trial, the MRC trial, it was almost double, and in the Dutch trial also, it was from 25% in D1 lymphadenectomy versus 43% in those two patients who underwent a D2 gastrectomy. In terms of morbidity, those patients, they had a high risk of anastomotic leakage. The pancreatic leakage was high because you tried doing a pancreatic section. Because of the complication, majority of the patients had to undergo reoperative surgery. The risk of bleeding was high, wound infection was high, and even the pulmonary complications were higher in these patients. So because these patients had prolonged surgery and there was a risk of bleeding, these patients ended up receiving more amount of blood transfusion. When it comes to further analysis of the mortality parameters, in the MRC trial, it was found that the risk of mortality was almost double, 5% versus 11% in D2 patient who underwent a D2 gastrectomy. And the Dutch trial, the risk of mortality was also double, almost 4% to 10%. And when you analyze the relative risk in those patients who underwent D2 versus D1, this one, relative risk was almost double that of those patients who underwent a D1 gastrectomy. But the question comes, like, why are these patients who are undergoing D2 gastrectomy ending up being more morbid and having more mortality? That can be explained when you analyze this. When you analyze this patient, about what percentage of these patients underwent splenectomy and pancreatectomy. In the MRC trial, a very significant number of patients underwent unwarranted splenectomy and pancreatectomy. And in the Dutch trial also, the amount of patients who underwent, the number of patients who underwent splenectomy and pancreatectomy was definitely high. So these patients who ended up having pancreatectomy and splenectomy, irrespective of whether they were in D1 group or a D2 group, the morbidity and mortality parameters were definitely high. That means your outcome in the terms of morbidity and morbidity is definitely influenced by doing an additional step of splenectomy and pancreatectomy. So leaving behind the bad news, so let's go into the good news. How effective is D2 lymphadenectomy in comparison to D1 lymphadenectomy? So MRC trial, it failed miserably to show that D2 lymphadenectomy has any advantages over D1 lymphadenectomy. So they ended up concluding that doing a D2 lymphadenectomy probably is not beneficial. The Dutch trial, so the Dutch trial had three reports. The initial report, then the second analysis came after 11 years, and the third analysis which came after 15 years. In the initial 5-year follow-up and the 11-year follow-up could not show any benefits, but the 15-year, the long-term data of these patients, the 15-year long-term data of these patients, it showed the better outcomes in along the all oncological parameters. That is, overall 15-year survival was better in those patients who underwent D2 lymphadenectomy. It was 21 versus 29%. Gastric cancer related death rate was definitely higher in those patients who underwent D1 lymphadenectomy. Sorry, and the local recurrence was higher in those patients who underwent D1 lymphadenectomy, and regional recurrence was also higher in those patients who underwent D1 lymphadenectomy. Again, the further details into these patients, why these patients had a better outcome, or why the patients with D1 lymphadenectomy had a poor outcome. That is explained when you observe the mean overall survival of these patients, that in those patients who underwent splenectomy or additional pancreatectomy or pancreaticosplenectomy, so they tend to live for a shorter duration of time because of the surgical morbidity and mortality in those patients is high because of additional splenectomy and pancreatectomy. It's almost double. If you observe those patients with in the Dutch trial, those patients who underwent D2 pancreatectomy, D2 lymphadenectomy without pancreatectomy or D2 with pancreatectomy, the overall survival was almost 8 years versus 4 years. So that means doing an additional pancreatectomy or splenectomy will negatively influence your final outcome. To summarize, outcome of D2 lymphadenectomy based on the present literature evidence, there is plenty of evidence to show that D1 and D2 are equivalent, but there is some amount of limited evidence on showing superiority of D2 lymphadenectomy. If you are able to maintain the morbidity and mortality to a minimum possible extent, then probably doing a D2 lymphadenectomy is advantageous. So, in order to reduce this morbidity and mortality, unwarranted resections of pancreas and splenectomy has to be avoided. So, now let's move on to the next question. Who are the patients in whom we should be offering D2 lymphadenectomy? So D2 lymphadenectomy is offered to those patients who has got any evidence of lymph nodal involvement, or any those patients who have got a tumor stage which is more than D2. But it's not always possible to 100% be 100% sure on your clinical imaging, on your imaging or on the clinical examination or intra-op diagnosis, to make sure that we are not leaving behind any patients who do not have any nodal involvement. So preoperative diagnosis regarding the depth of a tumor invasion and nodal involvement remains unreliable. Any doubtful patient with a possible lymph nodal involvement has to be offered D2 lymphadenectomy. Then when to do D1 lymphadenectomy?
Yes, Reetesh, in the clinical setting, I mean, the message should be that D2 lymphadenectomy is the current standard. So in gastric cancer, if you do operate, then you should perform a D2 lymphadenectomy.
So when to do D1 lymphadenectomy? So D1 lymphadenectomy is offered only to a select set of patients. Those patients in whom you try for a endoscopic mucosal resection or endoscopic submucosal dissection, but for some reason if EMR ESD is not able to meet the required curability criteria, but lymph nodal involvement is not high, so in those set of patients you can offer D1 lymphadenectomy. Or early stages of submucosal invasion, that is the T1B tumors which is less than 1.5 centimeter and well differentiated type, in them maybe you can offer a D1 lymphadenectomy. So what are the levels of lymph node dissection in those patients? When we say D2 lymphadenectomy, in those patients who undergo distal gastrectomy or those patients who undergo total gastrectomy. In the distal gastrectomy, so D2 involves removal of level of lymph nodes, level 1, that is right paracardial lymph nodes, level lymph nodes along the lesser curvature, the lymph nodes along the distal part of the greater curvature, suprapyloric, infrapyloric, and lymph nodes along the level 7. In addition, lymph nodes along the common hepatic artery, celiac axis lymph nodes. And when we say D2 in a distal gastrectomy, it does not involve clearance of a splenic hilum on a routine basis. That is the important point to be understood. And the same principle holds good in those patients who undergo total gastrectomy. We don't routinely clear the splenic hilum. So what about dissection beyond D2? So as Sir said earlier, D2 lymphadenectomy is the current standard of care for those patients who are undergoing surgery for a CS stomach. Either it is a distal gastrectomy or a total gastrectomy. So when do we consider dissection beyond D2? So it is considered as a non-standard gastrectomy as per the Japanese guidelines. So it is to be considered in a select set of patients. So as I said earlier, splenic hydra lymph nodes are routinely not cleared. So it is usually cleared when the stomach involves the greater curvature. Further details I will discuss later. So, and clearance of number 14 lymph node, that is the lymph nodes along the route of mesentery. These lymph nodes are also not routinely cleared, but it is advocated that these lymph nodes be cleared when you are clearing the infrapyloric group of lymph nodes. What about the lymph nodes along the posterior part of the pancreatic head, station 13 lymph nodes? So station 13 lymph nodes, whenever the CS stomach involves the duodenum, then the station 13 lymph nodes are considered as a regional nodes, and then it is advocated that they be cleared. So moving to the next question, when to clear or should not be or when not to clear station 16 lymph nodes. This is called as para-aortic lymph node dissection, acronym is PAND. So based on the current literature or society guidelines, routine dissection of lymph node stations beyond standard D2 is no longer indicated. The question is, can we clear D2 para-aortic lymph nodes in a prophylactic setting or as a curative intent? So JCOG 9501 trial showed that the prophylactically clearing D2 para-aortic lymph node has no advantage. Moreover, it is associated with higher rate of complication in terms of ileus and lymphoria. So routine removal of 16A2 and 16B1 station is no longer recommended. But what about removing those patients with a curative intent? In those patients who you know that the paralytic lymph nodes are definitely involved, the outcome in this patient is going to be dismal or is going to be poor. So the routine dissection of these patients are also discouraged because, as I said earlier, because of the poor survival in these patients. So that means 16 lymph nodes are not routinely removed. So moving to the next concept, so I will be talking about role of omentectomy, role of vasectomy, and role of splenectomy in as a part of gastric surgery. Uh, why these the basic premise of doing omentectomy, vasectomy, and splenectomy, why they are important is because it's presumed that when we do omentectomy, vasectomy, or splenectomy, you will be able to do a better loco-regional clearance. Maybe it is associated with a better survival. But is it really required? The Omega trial, which compared the role of omentectomy in patients undergoing a radical surgery, it found out that only 5% of the patients they had metastasis in the greater omentum. Out of 100 patients who underwent surgery, only 5 patients showed evidence of metastasis in greater omentum. So, and these 5 patients also were found to be having a very advanced stage of the disease. So the authors concluded that as the incidence of metastasis in the greater omentum is going to be very, very less, and it is likely to be involved when these patients are going to have a very advanced disease. And the outcome in these patients is going to be determined by the primary pathology of the disease, the primary severity of the disease, rather than be doing an omentectomy. So they recommended that omentectomy can be omitted. So there are some more studies which also have shown that just doing omentectomy, it is not going to increase your number of dissected number of lymph nodes which you are going to harvest, or it is neither it is going to increase your it's not going to increase the number of lymph nodes we are going to harvest, and the outcomes, the post-operative complications, overall recurrence rate, peritoneal recurrence rate, or a 3-year relapse-free survival, or a 5-year relapse-free survival in those patients who undergo omentectomy or omentum is preserved is going to be same. So that means there is an evidence that maybe we can stop ourselves from doing omentectomy. So again, there are evidences which show that omentectomy is definitely not required for a radical gastrectomy. But what are the societal guidelines? NCC and ESMO guidelines do not specifically mention anything about doing omentectomy as a part of gastric surgery, but the Japanese guidelines, they still recommend about that. They say that in those patients who have got a locally advanced disease, which is more than T3, greater omentum has to be routinely removed. For those patients with T1 and T2 tumors, the early stage tumors, they recommend about preserving a part of omentum at a distance of more than 3 centimeters from gastroepiploic arcade. What about the role of bursectomy? When we talk about bursectomy, it talks about the removal of the peritoneal lining of the bursa omentalis, which has to be removed as much as possible en bloc, involving the capsule of the anterior capsule of the pancreas with the lining of the anterior plane of the transverse mesocolon. Let's look into the evidence of doing bursectomy and not doing bursectomy. So the Osaka bursectomy trial, which was conducted in Japan, so they found out that in those patients who underwent bursectomy, particularly in those with the middle or lower third of the stomach, and in those patients who had the disease which was extending to the serosa, the serosal positive disease, in these set of patients, they had a better survival. So they recommended that omitting bursectomy may not be advisable. But the latest Japanese guideline, Japanese trial, JCOG 1001 trial, showed that those patients who undergo bursectomy, because you are going to remove the anterior capsule of the pancreas with the transverse layer of the transverse mesocolon, so these patients, the amount of blood loss is going to be more. So the morbidity in this patient, any grade 3 and grade 4 morbidity is definitely more. It's almost 11% versus 13%. And these patients will more likely to have a pancreatic fistula. The risk is 2% versus 5%. But when you compare the 5-year overall survival outcome in this patient, is almost the same. It is 76% across both the groups. So they recommended this JCOG trial outcome. They recommended that routine bursectomy did not give any advantage. So they recommended only to do a T2 distal gastrectomy along with omentectomy. So the Japanese guidelines, as of the 2018 guidelines, they do not recommend doing a routine bursectomy. Not only for any patients, they don't even recommend doing a bursectomy for advanced stages as far as T4A tumors, also for tumors located in the posterior wall. Also, routine bursectomy is not advocated. But the earlier Italian guidelines in 2015, they had recommended that you can do bursectomy for those patients who have got a tumor in the posterior wall of the stomach or advanced tumors. What about splenectomy? Uh, the role of splenectomy comes important when you have a growth involving the proximal stomach, because there is evidence that for those patients who have got a growth in the distal stomach, maybe spleen preservation is beneficial. But when you have a growth in the proximal stomach, uh, doing a splenectomy is going to cause more harm than any advantage, because the incidence of lymph nodal metastasis in these patients who have got the growth in the proximal stomach, but it is not involved in the greater curvature. The lymph nodal involvement is just around 2.5%. That means splenic hilar lymph nodes are routinely not involved. When it is routinely not involved, we are not justified in trying to go and meddle in that area and doing an unnecessary splenectomy. But what about those patients who have got growth in the proximal stomach and it also invades greater curvature? So the studies have shown that again in this set of patients, doing a routine splenectomy may not be beneficial because it is associated with significant perioperative morbidity in the terms of more blood loss, more pancreatic tail injury, and higher morbidity rate. What about the societal guidelines? The Japanese 2018 guidelines, the goal is splenic preservation. So they recommend that in those patients who have got growth in the proximal stomach, if it does not involve the greater curvature, routine splenectomy to clear 10 or level 10 lymph nodes is not required, and routine splenectomy is not to be done. But in those patients who have got in the greater curvature growth and there is some suspicion for a level 10 lymph nodes, so then uh, attempt to clear 10 lymph nodes with or without splenectomy can be done, but there is sufficient evidence for this is lacking. Italian guidelines also go on the almost the same line. So after now having discussed about the extent of surgery and other components of surgery, let's talk into about the resection margins in those patients with the gastric cancer. So the resection margin varies from country to country based on the society guidelines, but generally the accepted standard is we have to have a at least proximal margin of 5 centimeter for those patients with the intestinal type of growth. But if it's a diffuse type of growth, the recommendation is for 7 centimeter. The next situation comes what to do when intraoperatively you are not sure about your ability to get a resection margin. So then we can make use of frozen section. Is the frozen section routinely done? No, it is not to be recommended. It is not to be used routinely. It is usually done when it is not possible to obtain a proximal resection margin or a patient has got certain risk factors where the resection line margin involvement is going to be positive. Situations like those patients who have completed a neoadjuvant chemotherapy or a chemotherapy protocol where you are not able to determine intraoperatively whether margin is involved or not, those patients with the diffuse type of growth, again we can make use of intraoperative frozen section. The accuracy of frozen section is almost as high as 95%, but when there is a significant cell carcinoma or a poorly cohesive carcinoma is considered, the risk of false negativity increases. So what about those situations in which the proximal resection margin comes as positive? So are we supposed to go in and do a repeat surgery or not? The recommendation or general accepted consensus is when you have done a subtotal gastrectomy. So the situation to be considered whether we have a early stage of cancer or a late stage of cancer. When you have got an early stage of cancer in the form of T2, T3 with a limited nodal involvement, the negative peritoneal cytology, a repeat surgery can be advocated. But if the stage of the disease is more advanced, repeat resection in this set of patients is not indicated because the final outcome of the long-term prognosis in this patient is going to be determined by the biology of the disease more than your resection line involvement. What about those patients who undergo total gastrectomy? So it's a little difficult situation. The consensus is that in these patients, irrespective of whether you operated on an early cancer or a little more advanced cancer, so the decision has to be taken in a multidisciplinary tumor board regarding need to reoperate, because we might have to approach with a transthoracic approach because the anastomosis is going to be higher up in these patients. So moving to the T4A tumors, the role of multivisceral resections. So multivisceral resection, the concept for multivisceral resection in carcinoma stomach came from observations in carcinoma in studies involving the malignancy of the ovary and the colon, where the multivisual resections are usually done and which is associated with a better outcome. So when we say multivisual resections in CS stomach, it includes mostly the spleen, pancreas, liver, and transverse colon. So there are evidences which are coming up now that multivisual resections can be done. So because if you're not going to do multivisual resection, these patients are subjected to just a palliative chemotherapy. And there are evidence in the multiple non-prospective or retrospective studies that it is associated with certain benefits, but these benefits definitely they come at a cost. These patients, because you end up doing pancreatic resection or a liver resection or a splenectomy, so this is associated with a certain amount of complications and definitely an increased risk of mortality is present. And what about the survival? Because we are able to attain an R0 resection in this in selected set of patients, maybe that will give some amount of survival advantage. So one of the study which we need to look in. Hello. Hello.
Carry on.
Yeah. So one of the study we need to look in this set of patients is the FLOT3 trial. The FLOT3 trial was an interesting trial because it was a non-prospective trial, but in this they compared three set of patients: arm A, arm B, arm C. Arm A were those patients who have got a locally advanced, those patients who were resectable who did not have metastasis, and arm B had a patient with a limited amount of metastasis, and arm C for those patients who have got an extensive metastasis. These patients received a FLOT3 neoadjuvant protocol chemotherapy followed by surgery. So when they compared those patients in the arm B who have got a limited amount of metastasis, who underwent surgery and who did not undergo surgery, it was observed that in spite of having limited amount of metastasis, the median survival in this patient was 31 months compared to 15 months in those patients who did not undergo surgery. That means after receiving a neoadjuvant therapy in this set of patients offering surgery, that is surgery, the primary surgery with metastectomy had a certain amount of survival advantage. But again, this study stands in contrast to Regatta trial, that's the study from Japan, which recommended that doing a reduction surgery, which I mentioned earlier, has no advantage and it is not recommended. But we need to understand the difference between the Regatta trial and this FLOT3 trial. Regatta trial, those patients, as in Japanese practice, they received adjuvant chemotherapy, S1 protocol. So, and those patients underwent only gastrectomy. A metastectomy was not addressed in those set of patients. Whereas in FLOT3 trial, so these patients received neoadjuvant chemotherapy followed by surgery involving both the primary and metastasis. So this opens an avenue for multivisual resection in those patients who are having metastatic disease also.
Reetesh, you need to leave a few minutes for Dr. Yogesh to make comments.